Hey everyone, welcome. This is Jason Clemens, Doctor of Chiropractic at the Rock Health and Wellness Center, and this is Life with Jason Clemens, DC. We are live right here from the Rock Health and Wellness Center studios in Lubbock, Texas. We're on the radio at 98.7 Walk by Faith, 1420 AM, 987radio.com, all over the world. We're live on our Facebook, our YouTube, and our X, and we are ready to go. I hope you guys had a great week. Hope you're ready for the weekend. Hope you're going to get some rest and get back at it on Monday. You know, around it in a wellness world, Mondays is the best day of the week. Fridays are kind of a bummer because it's kind of like this. I'm going to be with you tonight, and then I'm not going to be with you for 48 hours. And then we'll be back on Monday night at 6. And so what am I supposed to do with all that time? I'll try to do something, try to find something to do with myself between now and Monday night. But right now we're here, we're ready. And I was just sitting here thinking before the show started, I was thinking about how cool my day was and how many different people I got to adjust and some of the things that we worked on. All the way from shockwave on knees and hips to shoulders. We did knees, hips, and shoulders and feet today with our shockwave. I adjusted a little baby who is about maybe 3 or 4 weeks old. I don't know exactly the age. I didn't have time to look that up when I was thinking about it, but she was 3 or 4 weeks old. I adjusted a kid that was in an accident and is paralyzed from the waist down. So he was in a wheelchair, and we adjusted him today. And we adjusted athletes, we adjusted moms and grandmas, and it was a great day. It was a great day, and that's pretty much typical of what goes on at the Rock on a weekly basis. You just have this wide spectrum of people that you're working on, and they're in all kinds of different situations, and some of them are very complicated. I had that conversation today. I had a conversation with a new patient that, he wasn't very impressed. It didn't seem to me like. That's my take on it, not his. But he wasn't very impressed with his first day in our office, and he came back today, and I could tell he was a little hesitant about what was going on. And I've learned over the years to be, try to be as serious as I can possibly be in those cases. It's like, look, if you're questioning what we're doing and you're not sure about what's going on in the office, then I want you to know that I'm not joking around. I'm completely serious about your health, and I really want to make sure that we get you what you need, if we can provide you what you need. And he had some really good questions, and he had some very pointed questions, and it was great. And we went over his stuff, and I think he felt pretty good when he left. And we'll see how that case turns out. But one of the things that I really tried to explain to him was that there are cases, or every person is different, and that and some cases are very difficult. And when you're working on something that's very difficult, there are more chances that things can go wrong, right? That makes sense. There's more chances that, hey, we might adjust you and you might get sore. We might adjust you and this might not be as good as you think, or you might be disappointed for a little while. But I'm assuming, and I told him this, I said, I'm assuming that the reason you came to the office is because you weren't doing well. Your back hurt. He's got a long history. He had a fall and off a roof 20 years ago. He had a really difficult last 20 years. He's had all kinds of things go on. And so I was like, look, I'm not going to promise you anything. I'm not going to guarantee anything. What I am going to tell you is that I think we can help you be better than you are, but it's going to take some time and some repetition, and we're going to have to use all the tools possible that we have at our available to us to make sure that we are can just if we can improve your neurology just a little bit, and if we can improve your inflammation level decrease your inflammation level just a little bit. And if we can improve the ligaments just a little bit, and if we can improve the muscles just a little bit, then we got a chance to add all those little pieces of improvement together to try to come up with something that's good for you. And so that was our conversation today. It was pretty good. I thought it was genuine. It was straight up. There wasn't any BS going on with it, and so I look forward to working with him. I hope he sticks with it long enough. One of the things about chiropractic care is that when you do wellness, it's a lifestyle and it's time. We need time and repetition. And over 21 years, I've seen that the people that really commit to time and repetition are the ones that do the best. The ones that have this just show up and get adjusted, come back in 6 weeks, 6 months, whatever it might be, get adjusted again. I don't think you have that. I don't think you have the full benefit of what chiropractic care can bring for you. So that was just today. Anyway, I thought it was good. Another one of them was a great case today because she came to me with a knee and a foot problem, and she came in today and she said, "I feel great. I'm doing really well. My knee doesn't hurt. My foot doesn't hurt. I'm doing really well. I'm enjoying my week. I'm having a great Friday, and I'm here to get adjusted." And that's what we did, and it was great. I was glad for her. Glad that she had that experience, and that's just a joy. It's a joy that is part of what we get to do all the time with the full spectrum of people, all the way from very young to very old. I think my oldest person I've ever adjusted is 101, and the youngest person, I adjusted him this week. We were talking about it too. And I told him he's 5 now, but I adjusted him when he was 7 hours old. And he and his little brother got adjusted. And I said, we were talking about that. And his dad said, Dr. Clemens was like one of the first 10 human beings you met on earth. And I was like, hey, that's cool. I believe it was on a Tuesday. I said, I think you were born on a Tuesday, because I was in Littlefield and I came back from Littlefield and saw him. But no, it was a good day. And then afterwards, hey, I went and got a massage today. I wanted to share this with you. If you guys need a great massage therapist in Lubbock, Lori Ann over at Eucalyptus Lane is fantastic. And I thought I'd put her number up on social media for you guys on the radio. It's 806-392-0528. 806-392-0528. One more time, 806-392-0528. Lori Ann over at Eucalyptus Lane. She just does a fantastic job. That the whole thing is set up. It's so professional over there. They do a good job. There's a whole group of ladies over there that work in that space, and it's just a great place to be. And it's very relaxing. She does a good job, and she can do all kinds of massage. And she's got some thermography that she started, where she can actually scan your body with a heat camera and then give you a report. That's really cool too. If you want to talk to Lori Ann about the thermography, I haven't had the chance to do it myself. I've studied it for multiple times over the years, kind of looking into it. But she got one of those cameras and is doing good with that. So that's something. Lori Ann over at Eucalyptus Lane, 806-392-0528. And that's that. I want to say thanks to the boys working today. Leslie and Caitlin have gone to Santa Fe for the weekend. The girls on Leslie's side of the family decided they needed to have a girls' trip. And I think it's the first one, 32 years. So they're in Santa Fe. They're having a good time, I guess. I talked to Leslie a little bit last night, and sounds like they're having a good time. But she runs our front desk, and she handles all the phone calls and all the scheduling and everything that happens at the front desk. And so with her not being here today, it was a little bumpy, but the guys did a good job yesterday and today, getting it all done and making sure we got everybody taken care of. And I just wanted to give a shout out to them and say thank you for the work that they put in. And um, they they pay attention. They're conscientious. They're good kids, and it was good to have them. It was good to have them, and I'm glad they were here today helping us out. So last night we talked about hip height and knee osteoarthritis, and I wanted to piggyback off of that thought, and I wanted to show a couple more X-rays, and I wanted to talk about a couple more articles that I got, and just it really talk. I think biomechanics is really cool. I think I had a lady today ask me. She said, "Is it if my neck hurts right here? Does that mean that the bones are out of alignment?" And I was like, "Well, actually, no. Your bones aren't out of alignment. I mean, that's really it's not." I know chiropractors say that, and I know it's become the normal thing. Man, I must be out, or I'm not lined up right, or whatever. It's like that's not really how it works. And I think as we move forward, in my profession, we ought to try as best we can to explain that that's not the way it works. You're not out of alignment. Your bones are not they're never out of alignment. If they are, you're dislocated. So the question is, why is this particular area of the neck not functioning right? And it's a whole unit altogether. That's what I tried to explain to her. I'd say it's the whole unit not moving through the proper range of motion or being stressed through the range of motion that's causing some sort of breakdown along the way. And it could come from your neck. It could be something going on in your mid back that's affecting your neck. It could be something going on in your low back or even in your feet, like all the way through from your feet to through your neck. You could have something like fascia running. We've looked at anatomy trains before. You can probably Google that, anatomy trains, and see some pictures on anatomy trains. I'll try it right quick. Here's just show you, see if there's some images. There's an image right there. See if they'll blow that up. Nope. I'll show it to you. It's on the internet. But I just went to anatomy trains. You can do the same thing there. It's a great book. I'm all signed up. I got the books. I'm part of the group and all that sort of thing. But you can see where this fascia, if I can blow that up a little better, the fascia there is it'll run from the bottom of your feet and it'll wrap around and it'll go all the way up. So you can go all the way from the bottom of your feet all the way to the to your skull with one piece of fascia. I always think of fascia as kind of like saran wrap. Like it's, how like at Thanksgiving you use you want to take some saran wrap or something and leftovers is the best thing. You put all the stuff in the fridge and then later on that evening you want to have some leftovers, and so you get the leftovers out and you got this saran wrap over the top of it. You try to take that off and get you some mashed potatoes or whatever you're going to eat, and when you try to put that saran wrap back on top of that mashed potato bowl, it sometimes sticks together, right? It's like it's hard to get it. You got to get right on the edges of that saran wrap and kind of like stretch it out and try to pull it back around so you can recover it. All you people that still eat mashed potatoes, you can recover your mashed potatoes and with the saran wrap. That's what when I think of fascia, that's what I think of. And so it's one part. That's kind of what I was saying with the complicated issue just a second ago. It's like it's one part of a whole, and we got to address the whole thing. It's not just a bone out of place. If your foot's not functioning properly and the fascia is attached to your foot, then you could be creating some strain or some torque or something on that fascia that's running all the way through your hips and then all the way up and around. I had a lady one time that she was having trouble with her knees. Her knees were really, well, she was a great example of last night, what we were talking about, where we had this internal rotation of the knees where you're kind of knock-kneed, and you've got that, your femurs have that internal rotation towards the knee. And she was having knee trouble, and then it was hip trouble. And she went to a physical therapist, and the physical therapist said, yeah, I think it's in your hips that's causing your knees. And I was like, nope, keep going up. And she was like, what do you mean? I was like, you got to get to your brain. I think the problem is all the way at the top in the brain. But the point of it is that if the brain's not functioning properly, your hips may not function properly, your knees may not function properly, and your feet may not function properly. So it could be all the way up and down. And when you're addressing something like that, I think it's proper to address the whole thing. That not just the bone, like the bones, is we adjust it, but you're never getting adjusted. I mean, very, very rarely are you getting adjusted because your bones are out of place. That's not the reason a person gets adjusted. They get adjusted because the function of that is not moving. And that's kind of what the complicated case was today. I tried to make that point. I'm like, look, he's like, how much chance do you think in this treatment plan you're giving me that I'm going to get structural changes? And I said, I don't think you're going to get any structural changes. And he was like, well, I said, you've got a bad structure and you've got bad function. And what I'm going to try to do is improve your function. And I may or may not get any structure changes done. And I can show you some examples of what I mean by that. That it's not the structure, it's the function. That's the problem. I don't know if that makes any sense to you guys. I hope it makes some sense to you. I hope it gives you an idea of, say, hey, look, can I make my life better by getting adjusted? I mean, I've got 21 years and thousands of cases that say, yes, you can do that. You got to follow the plan. You got to follow the plan. You got to stay on the routine. The in and out part of chiropractic will not get you where you want to go. It's not the best way to do that. So let me show you a couple more of these cases where it's where there's multiple things involved. Here was one that is a low hip. Yeah, so here's one right here where when you look at it, you guys on the radio, you can catch this at the Walk by Faith Facebook page if you're not able to see this. But what I've got is an x-ray, what we call an A to P lumbar x-ray from front to back. And you can see the hip height differential over here. The top of the ilium and the top of the ilium, this is the right side. The top over here versus the top over here is definitely higher. So we've got this left side that's dropped. It's probably a good half an inch or maybe even 3/4 of an inch that's low. And you come down to the femur height and you say, well, the top of the femur is here and the top of the femur on the left is way low. You also can look at the pubic symphysis right here, which, because this whole thing is a circle. And so you'll get this circle going on, and then the center of the sacrum that's probably almost an inch, maybe 3/4 of an inch. The center of the sacrum is 3/4 of an inch to the left of where the pubic symphysis is. This whole pelvis is rotated. We got rotation all through here. Now, the question that you would ask, based on last night's article, the question you would ask is this caused by leg length inequality? Does this person have a left short leg? Well, we'd have to measure it. And we can roughly measure it with a tape measure. We could put it on the hip, we could put it on the ankle, and we can see about how far that is. And we can say, well, that looks like it's pretty bad from one side to the next, but I don't know I cannot look at that x-ray. I can't look at an A to P x-ray and tell you whether or not you've got a leg length. I mean, very, very, sometimes it's super obvious, but I can't tell you if there's a leg length inequality right there or not, just by what I'm seeing. I'd really need to see the whole picture, and I need to measure that. But that could be a problem right there. And it all could be in the pelvis. Your hips could be out of alignment, which then that goes back to your hips. It's not out of alignment. Your hips could be subluxated. And then I tried to explain that. That's what I said to the lady. I said, well, you could be subluxated, and that could be causing your pain in your neck. That's really the truth. And then it's like, well, what does subluxated mean? And I said, well, it means interference in your nervous system. And then that gets complicated, right? It's like, well, how does interference in my nervous system affect this pelvis and make my pelvis rotated? Well, it's complicated. Like there's lots of stuff. Could be strictly that there's an anatomical short leg that's causing this, or it could be something different. And that something different is really what we need to try to address. Otherwise, we just need to put a lift in your shoe. And sometimes we go ahead and put a lift in the shoe. Just go ahead and get that done, and just put that lift in that left shoe and bring that hip up and let them walk around for a month, and then come back and then see how they're doing. Take the lift out and see if they've adjusted themselves just by moving. That's another way you could do that if you're not functioning right. If you think, ladies, if you're, well, and men, but ladies, if your hem lines are not right in a dress, and men, if you're dragging one pant leg versus the other pant leg, or sometimes you just know, or you just cut this. Another way you could do it is stand in front of a mirror. Just stand in front of a mirror and just let your arms hang down to the side and just check your own posture. And just look at yourself. Just close your eyes, stand in front of the mirror, just close your eyes, shake out your shoulders, then open your eyes and just see where you are. Are you lined up right? Are you straight? Is it straight from top to bottom? Does your nose and your sternum and your belly button all line up in a straight line? Or is your nose way over to one side as compared to where your belly button is? And then you might say to yourself, well, man, my back hurts all the time. And it's like, well, yeah, it's this whole thing is not functioning like it's supposed to function. There's just an example. You guys don't get to see them as much as I do. I get to see these every day over and over and over for years and years. And so when I try to explain it, I'm like, when I say it to you, I'm like, well, if you could have seen what I've seen. And so I'm like, well, why don't I show you some of the things that I've seen? Here's another one and we've talked about this one before. I think I've actually shown it on the show before, or at least the concept of it. But this right here is a lumbar curve that has a pelvis that's balanced. So this is kind of the opposite of what the leg length inequality issue is because now in this particular picture, what we've got is we've got a bent lumbar spine. We've got it bent and rotated. If you can see real closely, right here in the middle of this x-ray is the spinous process, and it's closer to this little circle over here, which is the pedicle on this side versus the one on the other side, which tells you have rotation. If you're looking at anything, I don't know what we could look at this orthomolecular bottle, this little area right here on the orthomolecular bottle, right there. It should be if it's lined up straight, it will be the same distance from each edge of the bottle. But if I turn it like this, and now that orthomolecular right there is closer to my finger on this side than it is to my finger on this side. That means we got rotation in that vertebra. They move. They're supposed to move, but they're not supposed to be lined up like that from the get-go. So how does a bone do that? If you have a misalignment, not being in the right place, just there. If you have an altered versus normal, here's normal over here on this side. Straight up, all the spinuses are in the middle, pelvis is balanced. Over here, straight up, the spine. We're not. We're coming off to the left and we're bending back to the right. If we have an altered shape or alignment versus normal, what would cause that? How come you would do that? Well, it basically comes down to one of two reasons. Number one, you either have a deformed bone, which that's sometimes happens. I'll show you. You remember when we played blocks when we were a kid? Back in the old days, we had blocks before we had iPads, right? So we had blocks. And then, so if you've got 3 lumbar vertebrae that are sitting there like that, and this one right here is deformed in some manner. So it's got one edge, it's down like that. What you'll get, instead of this lumbar, the one above it being right lined up straight, these are the spinuses. Instead of that being lined up straight, what this one will be is offset to the side. And then now we got to try to correct that. And so the next one above it will be offset. And then we'll start that curve back to the top. We got to take a break, but when we get back, we'll keep going. And then I got a really interesting article I want to go over about getting an injection in the disc and what happens if you do that. So you guys stick around with us. This is Life with Jason Clemens, DC. We're on 98.7 Walk by Faith. We'll be right back right after these messages. So if you've got a hemivertebra or some sort of deformity, then you'll get that curvature. That's one way. But in the picture that I showed you, that's not happening. In this x-ray right here, you can see how if you look right across, that's a vertebra right there. The one above it is a square. The one above it is a square. There's no deformity in any of those bones. So now we got to get away from the bone and we got to get into the soft tissue, the muscle, the ligament, the fascia. Why is this pulling over here on this side? And that becomes something that we can really work on, because if that's the case, if we've got a curve, if I have a normal alignment of 3 lumbar vertebrae, and there's the disc in the middle of them, that's a normal alignment. Well, but remember, you've got that psoas muscle. And that psoas muscle is going to connect from all the spinuses. It's going to attach to all 5 lumbar vertebrae. So that psoas is coming down through here, and then it's running. It's called the iliopsoas. It's running on the front part of that ilium, and it's coming down and attaching to the femur down on your leg bone, your thigh bone, your femur. That psoas is coming there. If that psoas contracts, you'll get this rotation to that side. And there's some other muscles involved in that rotation, but you'll get some rotation to where all of a sudden this thing starts to curve. And so now the question becomes, why does the psoas contract? Why are you tight on that hip over there on that side? Why is it so tender? If I press down right inside that pointy part of the bone right there on your hip, why is it so tender? Ow, that hurts. And I'm in that position right there. It's causing all kinds of havoc right there. Well, that'll come from your brain. Hang on. All right, everybody. Hey, we're back. This is Life with Jason Clemens, DC. We're talking about spinal biomechanics tonight, finishing on the second half of the show. It's going to be pretty cool because I got an article that's going to blow your mind a little bit. I think that about getting a shot in your disc. So we'll get to that in just a second because it does kind of fit into what we were talking about. And that's why I thought the article was pretty cool because it goes along with what we were talking about last night about knee problems. Remember, we got knee problems. And it's so cool because I've got 2 patients currently right now that both of them have internal rotation of their hip. And one of them has osteoarthritis, as they call it, bone degeneration in the knee. They've got degeneration in the knee on the outside of the knee. And the other person has degeneration in the knee on the inside of the knee. And both of those knee problems are coming from those hips in both cases. And both of those cases have an L5 disc problem. Think about that. Think about this person. We got a person, and we've got an L5 disc problem. We've got a hip problem, and we've got a knee problem. But one of them has a problem on the outside of the knee, and one of them has a problem on the inside of the knee. But both of them have a hip problem, and both of them have a lumbar disc problem. And you would think to yourself, hey, are those things related? And they are. I believe that they are. That lumbar disc is getting worn out because of the flexion that it's constantly in. And it's in flexion because it's not being held up. Remember last night we talked about those glutes? Talked about the glutes not holding us up. So we've got this constant flexion that's going on. And then we've got this internal rotation of that femur. An internal rotation of that femur in this particular case. I'm not saying that all femurs internally rotate. I'm not saying that. I'm saying these 2 particular patients have internal rotation of the femur. And now we've got this issue going on that's causing this knee not to function properly. And it's really cool because they've both been talked to surgeons. One of them canceled his surgery today. He's going to give me a shot to work on him. The other one is in the process of doing the same thing. She was going to give me a shot to work on her, and we're going to really, really try to get those hips. But I focused a lot on hip today. Even though the knee is the problem, I'm really focused on trying to get that hip joint to function right. And this particular hip joint's degenerative, and so it's going to be interesting to see if we can get it to unlock. Why has it turned in so much? And how long has it been that way? And is there anything we could do? Now, we got to look at him from top to bottom. We got to look at him from the bottom of his feet to the top of his head, and we got to look at him in his brain. So we're going to make sure that we adjust him. We're going to make sure that we drive the neurology properly, because that's what's going on with that bend in the lumbar spine. That bend in the lumbar spine that I was just showing you, that psoas that's running down through here, that's contracted, and what's happening there is it's not being inhibited from the brain on that side. So in that particular case, we got to adjust them over here, elbow, wrist, and shoulder, and work on that spine on that left side to try to drive through. And it's like, what are we doing on this Friday night? We're just all sitting here talking, and it's like, what is he talking about? Like, it's like, this is crazy. Yeah. Okay. We'll move along. It's just fascinating to me to get to work on this stuff. That's why Fridays suck. It's like, man, what am I going to do for 2 days that is going to match this? Nothing. There's nothing I'm going to do for 2 days. I mean, cleaning off the back porch. Are you kidding me? Like, all this stuff. Now, I understand. Don't get me wrong. I'm not trying to be, conceited for you guys, because I know all of you guys don't get to work on the most amazing system in the universe. So I get it that y'all like Fridays. But me, I don't like Fridays. I'm like, dadgummit, we got the most amazing system in the universe right here that we have to walk away from. I guess I could work Friday and Saturday and Sundays, but uh, we're not going to go that far yet. So anyway, let's look at our article because this is interesting. You guys might think it's interesting too. So let me find it. Nope. I got a couple different articles open. And there we go. All right. So this article says, does discography cause accelerated progression of degeneration changes in the lumbar disc? If you get a shot in the lumbar disc, does it accelerate the degeneration of the disc? Because that's one of the things that is never talked about when a person is trying to make a decision as to whether or not they want to get a shot in their back or they don't want to get a shot in their back. And I'm not saying that all shots in the back go into the disc, but that's a question. Is there, just kind of like what we talked about, what was it, on Tuesday night, Wednesday night, about the fever and the prednisone and all that stuff that we talked about earlier this week? We just take this stuff as if there's no consequence to it. And if you understood that there is some consequence to it, when you get a shot in your back, you might consider the fact that maybe I want to do something different, right? So this is back from 2009, October 1st. It's from the journal Spine. 2009 ISSLS Prize winner, International Society for Study of the Lumbar Spine. This study was done at Stanford University School of Medicine. Got a whole bunch of MDs that was on it. Study design, perspective, match cohort study of disc degeneration progression over 10 years with and without baseline discography. So what their objective was to compare the progression of common degenerative findings between lumbar disc injected 10 years earlier with those same disc levels in matched subjects not exposed to the shot. So we got an injection versus people who didn't get an injection. And then experimental disc puncture in animals and in vivo studies have demonstrated accelerated disc degeneration. Whether intradiscal diagnostic or treatment procedures used in clinical practice causes any damage to the punctured disc over time is currently unknown. So what they did is they took 75 subjects without serious low back pain, illness, underwent a protocol MRI, and an L3, L4, L4, L5, and L5, S1 injection examination in 1997. A matched group was enrolled in the same time and underwent the same protocol MRI examination. Subjects were followed for 10 years. So they took 75 people that had an injection in these areas of their spine in the disc. And then they took another group of people who had not had an injection in the disc. At 7 to 10 years after baseline assessment, eligible injection and controlled subjects underwent another protocol MRI examination. MRI graders blind to group designation scored both groups for qualitative findings. Loss of disc height and loss of disc signal were measured by quantitative methods. The results: well-matched cohorts, including 50 injection subjects and 52 control subjects, were contacted and met eligibility criteria for the following evaluation. In all graded and measured parameters, discs that had been exposed to puncture or injection had greater progression of degenerative findings compared to control non-injection disc. I think that's a big deal right there. In all graded measures, the disc that had been exposed to puncture had degenerated faster than the other one. New disc herniations were disproportionately found on the side of the annular puncture. So what does that mean? Well, let's get down for here. A quantitative measure of disc height and disc signal also showed significant greater loss of disc height and signal intensity in the injection group compared to the control group. Conclusion: modern injection techniques using small gauge needles and limited pressurization resulted in accelerated disc degeneration, disc herniation, loss of disc height, and signal in the development of reactive end plate changes compared to matched controls. Careful consideration and risk of benefit should be used recommending procedures involving disc injections. Now, I don't know if they're still doing disc injections since whatever that is, 16 years ago, but they found out that they weren't. But it says right here, new disc herniations were disproportionately found on the side of the annular puncture. So what's the annulus? The annulus is if you have a disc, then what you've got in that disc is you've got an outer shell called an annulus, and then you've got an inner part called a nucleus. That's not quite proportionally drawn, but that's kind of what, if we were to look at your disc from above and the spinal cord was here, I should probably show you what I'm drawing. So if you look down on it, you know when you cut a tree in half, you got all those rings in the tree. We've all seen that before, right? We know what that looks like. Well, that's kind of what that annulus looks like on the outside. And the outer one-third of the annulus has nerve supply. So and the blood supply, remember we drew this picture this week. The blood supply, I think we drew it last night. The blood supply comes down off the aorta and comes into the body of the vertebra, and it does this little winding. It looks like a coolant in an air conditioner kind of deal. And that's the way that blood supply, you've got to have blood supply to things. If you don't have blood supply to things, then they would die. That's what it kind of looks like. And so you got this disc with this annulus on the outside of it. It's got those rings, and you got that middle part that's got that nucleus. And so what they're saying in the article is if you take a needle and you come in here and you puncture that annulus and inject that with whatever cortisone you're going to inject it with, or what, steroid, whatever the steroid is that you get an injection with, if you come in and inject that, you are setting yourself up for degenerative issues 7 to 10 years later down the road. Like you're setting yourself up to have a problem down the road. Why? Because you're puncturing that annulus, and that's not a good idea to do that. We don't want that area to degenerate in any form or fashion. We don't want any punctures in that. We don't want to get in there and start messing that up, because that nucleus starts finding its way out. We got nerve supply on the outside. We got blood coming in and out from top and bottom. Got to make sure that it's moving properly, right? And so that's what the article is saying. It says that it 7 to 10 years after baseline assessment, eligible injection and controlled subjects underwent another MRI examination. Results: well-matched cohorts in all graded measures parameters. Disc that had been exposed to puncture and injection had greater progression of degenerative findings compared to control groups. New disc herniations were proportionally found in the side of an annular puncture. What is another way of looking at that sentence? New disc herniations Disc herniations. You guys ever had a disc herniation in your neck or in your low back? It is very, very uncomfortable. And especially if that disc, what does that even mean? Right? What it means is, if one of the ways, Stu McGill is the best in the world at explaining this stuff, but Stu McGill is the back pain specialist on earth. He can explain all this stuff. If you puncture that, plus you're not going to come in with that needle from the front anyway, so you'd be coming in somewhere back here with that needle. Well, what happens is, in a disc herniation, a lot of times, the nucleus is just looking for a little hole to find. It just needs a little bit of a hole somewhere, and then it'll start to leak around until it finds another little hole, and then it'll start to leak around, and then it'll start to build up and build up and build up and build up and build up. And now what you've got is you've got the outer part of it that starts to bubble around. And when that bubbles around and it hits the nerve, then you end up with pain. And that's herniated disc. What did I just say about my two guys that have the hip problem, the internal rotation of they have a hip problem, they have a degenerative knee problem, but both of them have an L5 disc problem. And what would be congruent? What is this flexion thing we got going on all the time? Right? Flexion. We flex that lumbar spine. We flex that lumbar spine and we push. This is the front. This is the back. We flex that lumbar spine and we push on that nucleus, and we push, the forces of it push backward. Because the front goes down, and it pushes everything out the back. Flexion. You may be sitting right now, you may be sitting and slouching wherever you are. And if you're sitting and slouching, you're sitting in flexion. Your lumbar spine, if you just looked at L4 and L5 or L3, L4, L5 and your lumbar spine, they're in flexion. It's like are you in a posture right now that has you in a sit-up? Like if you're doing a crunch, you're not meaning to do a crunch, but you're doing a crunch. It's like sitting on this stool. You see me, I'm constantly trying to roll my hips forward, make sure that I'm not sitting in flexion when I'm doing the show. I want to make sure that I'm constantly pushing that forward and making sure that my posture is correct in my lumbar spine, because if I sit here in this flexed position, what I'm doing is I'm pushing on that nucleus, and that's eventually going to find its way through there, and we're going to get this herniation. So oh shoot, I'm not even showing you guys this. Hang on. That's what I'm talking about. When you go to the front, you lean on the front of that disc, you push on that nucleus back there. And when I was in chiropractic school, there was actually some debate about that between whether or not if going to the front or the back caused the nucleus to move in which direction. But I think, according to Stu McGill, it's going to go backward. So you don't want that herniated disc. You'll hit that nerve and it'll run down your leg and it'll be miserable. You'll be hurting. You'll be in pain. It's not fun. Right? And then you might want to go get an injection. If you do, you just better stay away from that disc. Do not poke another hole. But what the article is saying that new disc herniations were disproportionately found on the side of the annular puncture. And what I would like to present based on this article tonight is I would like to present that new disc herniations are disproportionately found on the side of unhealthy annulus, period. Not just the ones that have been injected. The article, the study here gives us that information. It says that there's ones that were injected. Well, that's great, and I'm glad they did the article, and they won a prize for it, and that's great. But we can also use the same sentence and say, hey, it was found on the annular. Anytime that annulus is unhealthy, Anytime that annulus is unhealthy, it's unable to hold the nucleus from the middle. And if it's unable to hold the nucleus from the middle, it will if you compress it down, what happens is we get an in bone grows in the direction of force. You press down on bone and you start to increase the calcium deposits, the bone that's laid down at the end plate. When you do that and you lay down that bone at the end plate, you decrease the amount of blood supply to the disc. Now you can't get that blood through that heavy, because at first it's kind of porous and that blood just moves back and forth, right? It stays nice and healthy. But if that gets too sclerotic or there's too much bone in there, the end plates get too hard, then now we can't get that in there. So what will happen to the disc? Well, the disc will lose its nutrients and it'll start to shrivel up like a weed or like a flower that doesn't get watered properly. So then you'll get that's the whole thing of disc degeneration. It's like, well, we got disc degeneration going on. Well, why? Well, because my mama had it. I hear that all the time. Well, we've got bad backs in my family. We've got, because my granddaddy had it and my daddy had it. There's a good chance. Like, that's why I have degeneration. No, it's not. You might as well save that sentence for never. It's not. You don't have degeneration in your back because your daddy had degeneration in his back. Your back is not bad because your dad's back is bad. I'm living proof of that. It's like, no, your back is bad because you've been mistreating your back just like your dad mistreated your back. Your dad might be a great guy. He might be the salt of the earth man. Great human being. I'm not talking trash about your dad, but I'm just simply saying that his back might have been bad because of the same mechanisms applied to his spine as you're applying to your spine. And one of them is flexion. I spend a lot of time. I'll get on the side of the patient. I'll have them cross their arms in the front. I'll put my hand on the front of their arms in the front, and my left hand and my right hand will be on their low back. And I have to cheat and put my right elbow on my knee, on the inside of my knee, to help my legs support. And I'll spin that, I'll push with my left hand, I'll push their arms backward. And with my right hand, I'll try to use it and press forward and get them out of flexion. And some of those guys that I do that on throughout the day is so hard because when they sit down, they just sit down in slumped position. I could promise you, if you're sitting in slumped position, if you've got a rounded lumbar spine that looks like a C, if from your head to your tailbone, if it looks like a C instead of an S, you're pushing and you're creating this degenerative disc issue. You're increasing the chances of having a herniated disc. You're increasing the chances of low back pain. And I can tell you, man, remember we just did the one a couple of weeks ago, that the statistics say that low back pain increases, it just keeps getting worse with frequency and duration over time. We do not want to have low back pain. So what can we learn from the article? Well, number one, we can learn from the article, do not inject that disc. Stay away from injecting the disc. That's something that, now, as your chiropractor, I can't tell you whether or not you should inject your disc. That's between you and your medical doctor, because I don't do that stuff. But I'm trying to tell you from a health standpoint, it's not a good idea to penetrate that annulus with anything or to decrease the blood supply to that annulus, because then you'll end up with problems. And you guys have seen them. I'm not even going to bring all the X-rays out, but you've seen them, and we've looked at them lots of times. about what goes on with that disc degeneration, right? We don't want that. Maybe I got just a second. Maybe I could beat the clock. Hang on. Because I don't know if I can. There's so many of them. Yeah, there's one right there. Maybe. Let's see. Okay, right there. That's disc degeneration. That, you see how white that is right there? And then that end plate, and that end plate is all nasty looking. There's a bone spur on the front. There's a bone spur on the front. This right here is degeneration. This one's beautiful. This one's beautiful. This one's beautiful. This one's beautiful. This one is not proper, and that body's not proper. This body's not proper, and that disc is worn out, and that's going to get close to hitting the nerve. And when it does, that's going to run down your arm. It's going to make your hand hurt. And you're not going to enjoy any of that right there. So, hey, that's all I got for you tonight. We're out of time. I hope that was at least informational. Might not have been entertaining, but it was informational. It was, hey, something for a Friday night. You probably learned something. I guess you did. You guys have a great weekend. If I can help you, send me a text, 806-794-0400. Otherwise, have a great weekend, and I'll see y'all on Monday night at 6.